the main way that we determine efficacy really is by the patient reports or by family or caregiver reports. So if we see somebody in the clinic and the patient tells us that they haven't had a seizure and the caregivers tell us that they haven't had a seizure, I mean, that's how we determine efficacy. Now, there's going to be many times when the patient is unaware, whether they're having seizures or not, if they don't have a so-called aura, prior to their seizure, or if they don't have any injuries with the seizure, obviously they might just not know whether they've had a seizure or not. There's going to be many times when the caregivers are unavailable, they're not with the patient 24/7. So there are going to be times when the caregivers are not around, especially during daytime working hours where they might be at work. So having said that, the benchmark that is still used most commonly really is patient and caregiver reports. Now, I mean, there are certain devices that can be used, such as the Embrace 2 watch, where if somebody has a generalized tonic-clonic seizure, that's going to send a message to whoever is programmed, to receive that message that the patient had a seizure. So, I mean, there are some advances in technology that allow us to pick up seizures that are, otherwise would never not have been picked up. But really the benchmark and the standard for the moment that we use is still patient and caregiver reports. I think the main issue, with community neurologists would be that if somebody is still having seizures, I think they should really try to be very and more aggressive in terms of trying to get the seizures under control. Many, neurologists oftentimes think that if a patient is having a seizure, every so often, then that would be considered good seizure control. I mean, our goal should be seizure freedom always. So, and especially with the different, medications that we have available, the new mechanisms that are being targeted with some of the newer medications, we really want to keep seizure freedom as the goal and do really whatever we can to achieve that goal. Because anything short of that is going to really impact the patient's quality of life, put them at risk for injury, put them at risk for sudden unexpected death and epilepsy. So, I mean, I think they should just try to be as aggressive as possible about trying to reach that goal of seizure freedom as possible. I think the other advice I would give them is that they shouldn't really be scared about using some of these newer medications, because there's a lot of resources available, not only from the pharmaceutical companies, but from different meetings from different societies, where a lot of data gets presented about the newer medications. So I think it's important for them to just continuously sort of update themselves so that they are able to prescribe these newer medications as they become available. Now, as far as referring a patient to an epilepsy center is concerned, obviously, if there comes a time when they've tried 1, 2, or 3 different medications and the patient is still having seizures, and I mean, I think at that point it's appropriate to refer to an epilepsy center to see if they could be candidates for epilepsy surgery, could be candidates for other sort of investigational treatments or device treatments. Um, but I mean, I think a lot of the medication treatments can still be accomplished, at least in the beginning stages, by community neurologists. But certainly if the seizures become difficult to control, I think then it would be appropriate to refer that patient to an epilepsy center. Yeah, I think, referring back to the case presentation, and this is a fairly common type of patient that we would see in our practices. A person who is cognitively normal, who started to have seizures later in life, and the main issues obviously with this patient is that we're trying to get her back to work and be seizure free. And so, I mean, again, I think if we circle back to the goal of seizure freedom, and what would make a medication a good choice for this particular patient, we want to try to pick something that's once a day dosing, that is well tolerated, can be used at lower doses. So, I mean, I think even though perampanel is a medication that has only been around for like 5-6 years, it's still a very good choice for patients like this because of its sort of broad range of efficacy, both for focal seizures and generalized onset seizures. Um, and can be used at lower doses with good efficacy.